the reason why we organized this webinar is that we want to focus on a topic that is very important, and is the prehabilitation. So like getting patient fit before surgery or before a major stressor event. As we were saying with Stephanie and with René, it's a field that has a lot of studies that shows incredible outcomes on patients, both for patient and for hospitals, let's say, but Stephanie will talk a bit more about that. But it's lacking a little bit of implementation on the actual side. So today we're going to dive first on the rationale of prehabilitation. What is it? Some examples from Stephanie's career and knowledge, and then a little bit on the possibility of the digital prehabilitation that nowadays can assist and it can actually reach even patient that lives far from some sport facilities, or they don't want to go or cannot go in training in presence. So I will ask Stephanie to guide us in this magic world of prehabilitation.
I'm very happy. Thank you so much, Mattia. But you should give me the chance to give to open my yeah, I can see.
I just gave.
Now it's possible. I can open. So you should let me know if it's.
We see it.
Yeah. So I will share my screen. Is it possible to see?
Yeah,
if anything comes up, please interrupt me just. And if I talk too much, please do the same. Okay, so I'm happy to share some background about prehabilitation and cancer. First of all, I want to show you where Germany is, because probably we have some tendencies from the whole world. So Germany is in the center of Europe, and Ulm is in the south of Europe. And here you can see Ulm, the cathedral, which is the highest in the world. You can see here, that's in the middle of the city center, the old town of Ulm, which is a town at the Danube, crossing many countries in Europe. And this is just a part of Ulm University and University Hospital over there, you can see, and we are still building new buildings, and it's all the time developing more and expanding. So I want to talk about pre-op in cancer, about functional outcomes on pre-op studies in cancer. And I want to start with the topic of digital health, but then I will settle over to René and how we can shape the future for pre-op probably. So let's start with this. I thought it's a big problem also that we have rising costs in the treatment of cancer. So the total cost of cancer was 199 billion in Europe in 2018. That's so much money spent on cancer, and only for cancer drugs we spend 32 billion euro. And the total cost of cancer differed greatly between the countries. As you can see, Germany and the Netherlands are quite the same. And in Italy, you have much less money spent on cancer treatments. So health spending on cancer has been increasing faster than cancer incidence. That's really shocking. So first of all, let's talk about the different kinds of prehabilitation. Because there's no rule, actually, there's no definition on the whole topic prehabilitation, also in other diseases. So we can say we have one part that's called the multimodal treatment before surgery. It can be before, during, or after neoadjuvant treatment, like the chemotherapy, radiation therapy, etc. But it can also be, and we did a lot of experience in that field, before autologous or allogeneic stem cell transplantation. And last but not least, it can also be a multimodal treatment during neoadjuvant chemotherapy for first-line targeted agents, so patients who won't be operated. So different models. What constitutes prehabilitation? So it's the domain of tertiary prevention. It's the problem is the survival, complications, hospital admission costs, so many topics in this field, and prehabilitation of treatment-related symptoms or complications are always discussed. And also 1 in 3 patients undergoing major surgery is more than 75 years old. So we have a group of older people, and they have different diseases and comorbidities and different problems. And these geriatric patients are frail and sarcopene and have not only comorbidities, but also risk of complications and polypharmacy and prolonged hospitalization phases. And the value of cancer care has to be improved, and we have to work on the cost-effective treatment. So there was a group discussing trying to find out how can they define surgical prehabilitation. They did a scoping review of randomized trials, and that was interesting. They made use of a word cloud they did an inductive qualitative approach to define surgical prehabilitation. And by this approach, they found the following definition, and they said it should be prehabilitation is a process from diagnosis to surgery consisting of 1 or more preoperative interventions of exercise, nutrition, psychological strategies, and respiratory training that aims to enhance functional capacity and physiological reserve, to allow patients to withstand surgical stressors, to improve post-operative outcomes, and to facilitate recovery. So if we have a look at this, this kind of picture, if you ever had a look into trials or into these publications of prehab, you always see the same graphic. And it shows at first we want to have a better function, and we have a better function for patients who got prehabilitation before surgery. If here is the surgery, the prehab patients are always in a better condition. They don't lose condition like the ones who don't get the prehabilitation. They gain function, and they have improved metabolism and fewer complications around the surgery in the perioperative setting. And at the end, they have a better recovery. So if you have a look at this trajectory or cancer care continuum, there are different phases where you can have these prehabilitation phases. And that's a window of peri-treatment time period to prevent a treatment-related functional decline and its subsequent consequences, to improve functional status and physical and psychological health outcomes, to be a good basis for later early or post-treatment rehabilitation. And just to show why is this all very important, we can have a look on the imaging of a cancer patient with esophageal junction cancer. And in the beginning of the treatment of the chemotherapy, there's the body is in a let's say a good condition, and you can see the superficial fascia and the skin and the superficial fat area. And then you can see the muscle area and the visceral area. So blue is skin and fat, and the underskin fat, and red is the muscle, and green is the visceral fat area. But look at the decline after the chemotherapy, how it's different from the beginning, and the muscle is declining, but also the fat, which is not good. And we wrote some paper about that, also analyzed by an algorithm with KI. We had a look on the prognosis by this different kind of measurement, or how you say, technique. But this is not our first goal to have a look on. We just should know that 80% of complications occur in 20% of patients who constitute to the risk group, and these are the older people and the people who are suffering from many other diseases, and they have to improve function, because if they have more suffering from the surgery, they would have much more complications later on. So can prehab be a gateway to a better function at the end? For that, we have to look into the key outcomes, like patient-reported outcome measures, like clinician-reported outcome measures, objectives on physical function, and other ones like lymphedema, fatigue, or whatever. And currently, prehabilitative measures and clinical routine care does not exist. More than 9 million surgery procedures per year are provided, and an estimated 50% increase by 2040. That's a lot. And the risk associated with cancer surgery poses an impressive burden to patients and the healthcare system, as you can see in that publication. These effects could be greatly enforced by prehabilitative measures. We could, stop these problems gaining from all that different parts. And functional capacity is a strong determinant of a favorable outcome after surgery. Are there other effects and quality of life, length of stay, complication rates? Let's see. If we have a look on function and on the complication rate at the surgery, there is one great trial from, it's a multi-center trial. It's on colorectal cancer. 251 adults have been investigated if 4-week supervised multimodal prehabilitation program before the surgery sorry, of non-metastasized colorectal cancer could reduce postoperative complications and enhance functional recovery. And as you can see, the prehab group was in all settings better. So they had improvements in function and in their performance. They always have been better than the standard of care group in this performance, like 6-minute walking distance or hand grip strength, or also weight, or other ones. So they had fewer complications, but better recovery. And that's by that you can not only keep their quality of life, you can at the end save costs. And there's another example for that in radical cystectomy. That's the same with faster recovery at the end as an outcome. And there are different nice, very nice papers you can read. That's why I put the source into, because this one is also nice. It shows the aspects of prehabilitation for the treatment pathway. This group developed a toolbox where they had a look on, and they did risk assessments, or they recommend to do risk assessments and to look, of course, in the FIT principles of prehabilitation exercise. So you have to look into the frequency, intervention, the time, the intensity, the time, type of exercise, and of course also in the intervention. But here you can see the the whole graphic with all these parts of the FIT principle. And you can look onto the outcome measures, nutrition, for example, patient blood management, mental well-being, and economic potential. So there are many different aspects of prehabilitation. It's not only one. Yeah, and also in Ulm, we do trials on prehabilitation, and we started with a project. It's a prehabilitation in integrative medicine, and we conducted a trial and built up a day clinic for patients undergoing neoadjuvant treatment. That was a single-center feasibility pilot study, and we investigated the outcomes, the feasibility of the day clinic. We used several prompts like these questionnaires to find out how is the quality of life and the psychological situation. And of course, also the complication scales like the Hlaeb-Dindot and physical performance, adherence to the neoadjuvant treatment. That was also one of the outcomes. And just to show you one outcome, like the 1 minute sit to stand test, we found out that the patients could reach out almost 4 attempts more in 67 seconds after joining the day clinic for about 8 weeks. So this was just only one example for the success of this day clinic. It was most important for the patients to meet each other, to have the social interaction and the exchange, and to be together with other ones suffering from the same problem. I can't talk so much about it. We started the first part of this trial in a closed setting with a longer time we spent together in this day clinic and investigated the feasibility, as I told you before. And this was before, during, or after neoadjuvant therapy. And then we shifted it because it was difficult to recruit. Sorry. We shifted it to a continuous program. It was before, it was a closed setting. And then we reduced the time and the whole period, and that was a bit better for the patients to join, to participate. And now we are setting up a new trial, which also includes, and that's interesting for our group here, which also includes an online setting. So we want to compare, is it possible to reach out similar effects with an online training as well. So we compare present to online. And yeah, to treat the patients well, I developed a model. Like, I start with a screening, have a look at their condition, making use of assessments, of course, analyze the data, prescribe a program, and we do some individualized training. And of course, this is always continuing process, and it can be very different. Some people maybe need breathing techniques, the other ones need mobilization or strength or endurance training or whatever. It depends on the status of the patient. So it's very different. And yeah, concerning the digital health, the use of technology in cancer prehabilitation, there is a nice systematic review. I don't want to talk about that too much now because we want to discuss more. So just to let you know, there is some research on it, but not so much. And as we can see, the different technologies which have been used are shown in this table here. And if you have a look on apps, and that's our topic today, you can see there is one tribe from the Netherlands and one from the UK and one from Belgium. That's all concerning apps. Yeah, high quality evidence is very important. We want to have more large-scale, appropriately powered multi-center trials that have unequivocal, clinically relevant and patient-centric endpoints. That's the problem with the existing studies. They are not in the best quality, and they are very heterogenic, and they have some different quality problems. So technology-based prehabilitation programs seem feasible, but the effectiveness depends on intervention design and technology employed. Future research should focus on developing robust evidence to guide clinical practice and explore the potential of integrated technology solutions. This you can find in this paper, more about that. So how can we shape the future? What's our goal? Of course, all of us, we want to have we want to see the increasement of the preoperative functional reserve, which leads to a better postoperative functional recovery and a lower incidence of complications, and at least to lower costs. And all that needs to be facilitated and structured, and it must be a tailored approach to optimize physiological reserve and functional capacity of frail, high-risk surgical patients over several weeks pre-operatively. So is prehabilitation the gateway to better functional outcomes for individuals with cancer? Yes. And we need to develop standards for prehabilitation and integrated patient-centered care concepts, including screenings, assessments, and interventions. So as a summary, is prehabilitation the gateway? Yes, it is. As I already said, there is a need for transformation and a paradigm shift. Effective implementation of pre or rehabilitation into the cancer care process. We need early access to PREA programs, which should be standard. I also visited the colleagues in Barcelona who already have their own clinic for that, or I also visited Franco Cali in Montreal, who also has his own clinic set up. It's the same in Barcelona. They work in the same concept. And so patients should have early access, and we need to develop digital health solutions to have a better source also for patients living in remote rural areas who can't attend to the programs we are providing. And high quality research with clinical relevant, patient-centric and disease treatment endpoints is also needed. So the development of standards for prehabilitation and integrated patient-centered care concepts and process, including screenings, assessments, interventions, I already said. So we need to also care for the we also need to care of the patient requires also care for the provider. So we need some support at the end as well. So we don't need chronic diseases, we need chronic health. That's what I wanted to show you in a very short time, because we want to discuss this. Also should only be a kind of introduction so that we have enough time to discuss more further. Thank you very much for listening. I hope you could follow my my talk. I stop the presentation so we can see each other. Maybe, I don't know if it's possible, if all the attendances can open their cameras. That would be much more nice to see each other when discussing. And also, I don't know, René, if you will share your screen or if you will just want to yeah, show your ideas.
Yeah, there are no further questions, Stephanie. Great presentation with great topics. I think this is the well, the blueprint of what's going on in the land of prehabilitation. Unfortunately, not worldwide, and there's a lot of things to do to get everything implemented. I also want to focus a bit on that, how it's going in the Netherlands, but I'll share. Is there no one else, Mattia, that has a question already or something especially want to be discussed?
If anybody has a question, feel free to activate your camera, to activate your microphone. We are totally in a flexible environment, and absolutely. And thank you, Stephanie. What you said is really powerful and super on point. And I think, yeah, like seeing your presentation made me think that the prehabilitation is the definition of a win-win situation for the patient and for the hospital. I have no other definition for that.
Yeah, that's right. But I think it will be a long way until we are until we have this program for every cancer patient, because it takes time to show a strong evidence. We have some evidence yet, but it's not with the best. The effects are not as strong as we thought. But now with this first Molenaar publication on these 251 colorectal cancer patients, this multicenter trial, this is a very strong evidence which shows that we can reach out less complications in the perioperative phase. And that's very important to investigate more of this clinician outcomes. We need more clinical outcomes, and that we can reach out a better performance when we train the patients, that's for sure. But we need to find out how we can improve the journey of the patients.
I think also it's studying how people can change in only 4 weeks' time. So when normally someone trains for an event or something, not being a surgery, well, your training time would be much more longer than a period of 4 weeks. And that is also what kind of expectation can you have more to increase the results of only 4 weeks of span?
That's a very good point, René. Thank you for mentioning that, because there is also one study showing that you can reach out different, that you have effects in just 1 week. In just 1 week. Every day some training. And of course, that's because these patients are in a very bad condition. So the worse the condition, the more you can reach out.
Exactly.
That's the best. So if you are an athlete, you have only very, very few differences.
It may not even be necessary to undergo a fit plan when you're already an athlete, of course, because what improvements can you make? You won't be an athlete, first of all. So that is one of the things. But there's also another thing, I think, I'll be on the topic later on. We have responders and we have non-responders, but we have also had late responders.
Right.
So from a morphological side, people can change by increasing, for example, being more tuned on your body or having more muscle and everything, or losing your weight, which you can see with your eyes. But we're also looking for the biomarkers to see what kind of insights changes are going on right on in the first 4 weeks. And by some people, we know there could be over hundreds of items that can be changed by doing exercise over time. And some people are late responders. They only respond after, for example, a long neurological time of adapting from your exercises, for example. And after that time, when they're fully neurological adapted, they're also going to have some changes on the morphological side. So it's also one of the things to find out in the future.
Right, that's very important, this physiological background, the pathophysiology and the different kinds of, it's also in men and women, so the sex difference is one topic. As you mentioned, the response. It's also the response to the responding to the treatment. So some patients are non-responders to the chemotherapy. But in my opinion, if we add the right exercise mode, we could reach out a better response to the therapy. And so we need to investigate the synergistic effects, but it's very difficult to show causalities.
Yeah, and there's another thing, and that could be done with screening algorithms and everything. I'll focus on that later on again. But it could also be, there's of course a guideline of treatment, how to treat someone who has diagnosed with cancer. Also, when it comes to when should things take place. But it could also be that perhaps it's possible to extend the data for surgery, for example, and just do 2 more weeks of training. It could affect a better outcome. You don't know. So that's all kinds of research. How long does the prescription of a training plan or a rehabilitation plan in his white side should be to have the best effects, but also don't forget the best effects for the surgery.
Right, and for that reason, the prehabilitation phase shouldn't be longer than 12 weeks. Exactly. That was one trial showed if it's longer, it can interrupt the
guideline of the treatment.
Yeah, right, and it could harm the patient, and that's not our goal.
Yeah. Yeah. Okay. Are there some other questions, Otto?
I don't know if somebody from the attendance has any question. Feel free to pop up and ask.
Yeah, or possibly anyone wants to add anything we didn't mention yet. Maybe there is someone who has its own experience and probably some suggestions for us and all of our group here. So feel free to.
It's interactive.
Exactly. Oh, well, I want to waiting if somebody yes, you can even write in the chat. I can give you one of mine because in the center I'm working, we are doing a trial on colorectal cancer patient in prehabilitation. They are geriatric patients, and it's happening exactly what you both said. We're doing a strength training test on technology machines, and I've seen in 4 weeks, and in 4 weeks the schedule is 2 sessions per week, but they are geriatric patients, so they are not autonomous. They have to be driven to the center. So also the pre-rehabilitation studies, I think they have some intrinsic limitations depending on the cancer type, on the age, but since you have a short span of time in which you can do the intervention, I've seen that sometimes patients miss some session, or they have another visit booked for the same day. So it's I think the evidence is not that huge at the moment, also for those limitations. It's a short span of time. You have to do a lot because nutrition, exercise, psychological support, lifestyle modification. It's a lot to take, especially if all those appointments are in presence. For some people, it can be a burden. And also what I want to say is that in Italy, there is a law that patients with the primary indication of surgery for cancer should be, by law, should undergo surgery within 1 month.
Exactly.
Exactly. But in our case, since they are geriatric patients and most of them are really at risk for the operation, they extended the time of, like they gave us the possibility of 6 weeks,
Very
because
good.
they think, like the surgeon thought that it's better for them to wait another couple of weeks and to undergo a proper prehabilitation instead of going into surgery, and maybe they are unfit, and we're talking of like 75 plus, I think. So
Yeah.
some can have comorbidities, being not autonomous. So yeah, as you said, you mentioned these 2 examples, and I will dive into the second topic of our talk, which is the digital part, because as I was saying before, the feasibility of prehabilitation sometimes can be tricky in terms of, let's say, a patient cannot go to a clinic, a patient has, for example, problem to be driven, is feeling too sick for doing that. So I think that digital solutions are a great help because of that. I saw, thank you, Paolo, for your comment. And at the end of the session, if you have some more specific question, feel free to stay and we can discuss. Okay, so now I will give you the floor to René and to talk about the digital possibilities of prehabilitation, since we are in the era of digital technologies and health is getting digitalized more and more. So what's your 2 cents on prehabilitation, or even more?
Yeah, thank you, Mattia. I will share my screen first of all. So this one, connect this one, and then I'll show to the side. I'll go to rehab, and please tell me if you can see it. Can you see my presentation right now?
No.
Not yet at the moment.
Not yet. Well,
maybe I can give you some.
Let me tell you if you have shared the screen. I'll do it again. Click on it, screen, this one. Can you see something? Or only yourself?
No.
Not yet. I can try to make you. I will try to make you the organizer, so maybe you can try now.
Okay, do it again. Wait a minute. Share my system. This one. Something changes already? Uh-oh. You don't see anything?
Not see. No.
That is very strange.
Yeah.
I followed the steps you asked me to.
If you want, you can send me the presentation and I can share for you. It's
okay. One moment. Oh.
Yeah, maybe I can
Yeah, go ahead.
use the time. And I saw Paolo wrote in the chat that he's happy to get some information about prehabilitation. And of course, we are all happy to help in any cases. If you have any further questions, just write an email to us and we can try to help you as best as possible, share some more information, or give you some recommendations how to set up a program, for example, so we can improve implementation more fast, maybe.
Yeah, absolutely. Also, Paolo, since we are both from Italy, if we are close by geography for some reason, we can also discuss about it. I really would like these prehabilitation methodologies to really go beyond the let's do a trial about
Oh, wait,
it.
I'll go log in again and I'll try it again, okay?
Yes, sure. Yeah, as I was saying, like to be implemented, because for the patient we are seeing in my center, in the center in Cesena, we saw really incredible results, especially, I have to say, especially on the elderly. The
Yes.
elderly really needs that. Um,
And I can confirm, I saw it personally. I'm very happy to share that I could, that I was able to get a special, a show of Mattia with his patients, and I visited the center. It was amazing. It's fantastic. Also the
Thank you.
outside area with gardening therapy and everything. It is beautiful. It's great. Also art therapy, dancing therapy. It's fantastic. Amazing.
Thank you. Thank you for the kind words. Okay, yes, René, we can see. Do you hear us, René, and still?
He must unmute.
My, oh my, oh my. So again, I'm sorry.
Okay, yes, we were seeing the presentation. Yeah. Yes.
And I'll show the screen, of course. There it is. You can see it?
Yep.
Okay. Again, I said, thank you so much, Stephanie. When it comes to the total landscape of prehabilitation, I want to focus some more on the side of digitalization, but also how prehab is organized in the Netherlands. Well, you see the current situation, next steps. My name is René Loek. I'm the founder of the Vivica Health and Lifestyle. And I'll tell you something about our own organization, what we're doing, and how we can improve the current landscape of prehabilitation, first of all in the Netherlands, but also with a worldwide focus or scope. So let's talk about some things about our company. We have two companies which I will start to introduce to you, Vivica Health and Lifestyle and Evidencio. I will tell you something about the Netherlands. I told you how it all started and where we are right now. What would also be the obstacles for furthermore upscaling prehab in the Netherlands. But also I want to focus on some next steps, which also a few of them were mentioned by Stephanie, of course. But what can we do for the future to also get those things like value-based healthcare, which is one of the most important things when you define some new interventions in this landscape. And with all that, I want to show you some screens of how Vivica can be used in settings for clients, for patients, of course, but also for research institutes, collaborations of hospitals and everything. So first of all, I want to show you something how it all started, because before we had the Vivica Health and Lifestyle application, we had an application was called Ping Trainer, and it all was an idea from one of my colleagues, Monique. She was a cancer patient, 2 times breast cancer patients, which has, as you can see, she was undergoing the total treatment, trastuzumab, all kinds of chemotherapy, radiation therapy, hormonal therapy afterwards, but a good focus on her. She became a world champion in the Natural Bodybuilding Association, and even only 6 months after her last chemotherapy. She was fit, but she also stayed fit by training very, very hard during the curative phase of the treatment. And 3 months later, she also won the European title for that. She's only a little small girl, if you see her in real life. But she had the idea to make an app which was called Ping Trainer, totally focused on only breast cancer patients. At that point, only women. So in the Netherlands, we have about 150 men a year who was also being diagnosed with breast cancer. And later on, the application was built on for that. But that's the total when it comes to where our initiative came from. It was Monique's idea. to make an app, first of all, and later on a big platform that could be used by healthcare providers. So let me tell you something about our two companies. First of all, Vivica Health and Lifestyle. We are a company in the eastern part of the Netherlands, about 32 employees within 3 companies, but two of you, I told you, will introduce yourself. What is Vivica Health and Lifestyle? It's an e-health application which has, first of all, a dashboard. I'll show you later on. And an app when it comes to the patient side. The healthcare providers, the dashboards, and all kinds of tools and instruments are inside that, and is real-time connected to an app for the patient. And therefore, we can facilitate some medical pathways, or you can call it patient journeys, where we can send a lot of information, inform them about the treatment from diagnosis, for example, how to prepare on every event, what's going on in the hospital, but also to recover afterwards. What's going on in chemotherapy? What can you take with you to chemotherapy? What kind of questions can you ask? With videos, with informative passages, but also with chats and everything. So I'll show you later on. The total application is also added some features when it comes to lifestyle aspects. So when you come to a healthy lifestyle, we're talking about exercise or moving, being sportive, nutrition, sleep, mind, non-smoking and non-alcohol consumption, of course. All these kinds are very personalized tools within the application. We can calculate totally on macro and micronutrients when it comes to nutritional intake, and we can be reported on the same measurements also. So with a tracker, a food tracker, with a scanner for food products in the supermarkets, with reaching your goals. And also there are a lot of tools inside for sleep, for mind. There are 800 exercise sessions inside with different kinds of settings when it comes to intensity variables. So on the other hand, it is domain specific. So that means that we have certain kinds of modules, oncology, cardiology, for example, as you can see here, bariatric surgery, neurology, and the latest one is for Alzheimer, where we are focusing on the progression of Alzheimer during a specific time and the influence of people who has counseling on lifestyle aspects or not. So how can we reduce the progression of Alzheimer over time? It's very, very great topic to do. But for bariatric surgery, of course, people were prepared for the operation, but also they have to be prepared after the operation for treating themselves at home site. So also there are different kinds of pathways you can set up for these specific kinds of things. And what does it mean? For oncology, we can track, for example, side effects which can occur during the neoadjuvant chemotherapy as a side effect result of using these kinds of medications. People can score it in the app, but they also get immediate some first tips to have self-management on treating these side effects. And when they're exceeding a certain kind of level or threshold, there will be notifications, and also the hospital will be notified that there are occurring more side effects. So you can be very preventive to these people with an intervention and take contact with them. Just to give you some impressions, on the right side, of course, you see the healthcare professional dashboard with different kinds of dashboards, items in the main profile of a patient. And on the left side, you see an app where, in this case, the screen shows you a kind of calendar task list where people get day by day specific things to do for the day. There could be a recommendation on nutrition, could be recommendations on topics of exercise or activities, but it could also be a motivational chat, everything what could be possible to send to your patient to optimize the patient journey, and also keep that patient aware that self-management is a very important thing of getting better themselves. It's the part that they, with digital health solutions in the Netherlands, be taught about. So this is your part of getting better. We are doing our part, but please use the app, and we inform you with all kinds of messages and information by the app, or sending questionnaires. On the right side, you see the dashboard, and you can see there are several measurements displayed with colors, with graphics, and you can, well, set up total every part what you see in the dashboard you can set up within the app. We can also individualize to say, oh, that's not what I want to know for this kind of patient, so I'll leave it out in the dashboard and I don't activate it in the app. I'll come later on to next features. So some more topics of that. Within the app is also, and I hope you know it, the 𝗣𝗁𝗵𝗯𝗶𝗃 book Tiny Habits. Well, again, from side self-management side, the patient can set up some little changes in their behavior. In certain kind of habits that are not healthy, they can change them into some healthy habits. But the trick here is that they are tiny. That means they are achievable. The mental barrier for doing this kind of habit is not high. So it's depending on events on the day. So for example, if I wake up in the morning, I do 5 push-ups. Well, everyone thinks 5 push-ups, I can do that, I will start with it. And over time, they are much more easier to do, and they are changing their current behavior into a behavior who has some of these tiny habits. And they can be tracked by the app. They get some compliments or motivational quotes that are doing a good job. Everything is inside the app integrated. But again, it's also for, when you call it on prehabilitation, a total one-and-all dashboard. That means that we can also track prehabilitation-related blood values or other kind of measurements which are on the continuum of cardiovascular, respiratory measurements, some kind of questionnaires. All kinds of questionnaires can be made themselves, but you can also use the current set of questionnaires inside the application. Test protocols. Stephanie mentioned some sit to stand tests, 1 rep maximum. All kinds of protocols for the test are inside. You only have to register it. The formulas do the rest, and they will be registered in the dashboard when all the data comes together. So one app where people can register it, but you can also register it from the dashboard himself, of course. And all these data of nutritional, of exercise, of feeling fit, whatever you want to know, it's all in one dashboard to look at it. Another thing is that we have, it's not good enough, connectivity with all activity trackers. So your Fitbit or your Garmin's, they can be attached by the and connected to the app by the patient itself, just by a little simple procedure to execute. And all kinds of information will also come into the dashboard with kinds of graphics, with all kinds of tables where the data are displayed in the app and in the dashboard. But you can also set up in the program of the dashboard, and perhaps Mattia, you will show something of that later on, what kind of activities you will schedule in the program. So people have to do these kind of day by day. So that means with the total dashboard and with the total Vivica library, where there's a lot of content inside, also when it comes to videos, example videos, topics about lifestyle, topics about cancer, topic about the operation surgery, how to prepare, everything is inside, tracking medication. So you can set up your own patient journey and provide it to your patient or patient groups if you're having some groups which start together. That's one of the things. So what we do for the researchers and also for hospitals that collaborate, so like a research topic which will be executed by several hospitals all over the world, we facilitate that with our total platform. So it's not only for clinical use in setting of a hospital or in a prehab or rehab facility, but also when it comes to research project. And that we have some special tooling inside. That means we have an overarching dashboard which can be connected and with several specific modules like live tracking of data or setting up some specific programs which are centrally built and can be used by every connected hospital. So you have one, in Holland we say you don't compare apples with pears. So you have one dashboard, you have one setup for the program, and everyone can register it and execute the program as everyone else does. So all these hospitals can go in that room of development, but on the other hand, you can also set up a kind of team who only makes these programs in the environment. And well, it's I said before, everyone can use it. So all these data from this central setup programs, which are collected by the patients of the hospital and the healthcare professionals, come together in that first overarching dashboard with the specific modules. But you can also then see all these data coming together in graphics or in just numbers or tables in one screen live. From hour to hour, there will be a refreshing of the data tracking in the screen, and you can see in one screen what the efforts are from all hospitals over the world using this program. Whatever you want, we can set up the queries, we can set up your dashboard, and all kinds of data which are outcomes which you want to see on live, so not on a, for example, later on investigation to investigate your specific outcomes. Sorry, you can see a lot of data live in the screen. And of course, there's a direct option to download your files to make some more queries in, you all know the CSV files for that. Okay, a total different company. What we also have is Evidentio, and we are the European leading medical algorithm dashboard platform or application, which we do two kinds of things. So first of all, we having a dashboard where people who want to develop a algorithm, AI, machine learning, all kinds of different algorithms can be built up within our system. First of all, they have to be certified when it comes to use in medical settings, because they can be decision supportive, they can be predictive, and if you want to change your treatment on that outcomes, the algorithm has to be certified according to the MDR standards. And that is also a project that takes about 200 to 400,000 euros to pay one certification for an algorithm. So our company can do that within the time span of 3 to 8 months, when normally 2 to 4 years is the norm for that. So that's one of the things, and about 70% of the costs. And that means that your algorithm in our platform, we are the legal manufacturer, but it's also available for all kinds of hospitals all over the world. The IP is, of course, for the one who makes the algorithm, but we can enable them for global and clinical use of these AI algorithms, and they are certified for using in hospitals within the medical device regulation standards. So there are different kinds of standards to use them. So that means, of course, for our own company, as when it comes to using algorithms within the Vivica dashboard, a great step of doing these kind of prehabilitation programs. So normally you have to make your own, you have it on your own site, your own server, and no one else can use the algorithm, and no one else can use the data, of course. So this is an algorithm that can be used all over the world with all kinds of hospitals collaborating with each other. And currently we're having 8,000 medical algorithms inside, every kind of things. One, for example, someone is diagnosed with breast cancer. You enter the diagnostics characteristics, then you are adding the treatments, like what kind of dose, what kind of treatment you have in your guideline for this patient, and our algorithm will calculate the survival rate for this specific treatment for that specific patient. So it could be supportive to change something of the treatment, or to change something where you can change it when it comes to the guideline. So that means there are a lot of algorithm possibilities. There are about 24 oncology which are certified and ready to use in hospital settings. About 21 for cardiology. We have some for neurology, a lot of them. So how does it work? On the left side, you see there are academia, pharma, industry collaborations of hospitals where you can make your algorithm. You define it. There's some scientific output, of course. It's all stored inside 𝗖𝗿𝗻𝗄. We take the legal manufacturer on our side, and there's a deployment of this algorithm with an API. That means that all hospitals can connect to the 𝗖𝗿𝗻𝗄, use to set up the data into the algorithm, and it comes back into their own patient file with outcomes of the question you asked to the system. So on the right side, you see it. There are a lot of normal how you can use it. Okay, let's go back to prehabilitation and how it all started in the Netherlands. I'll show you something, because first of all, a couple of years ago, there was, before prehabilitation as a word was introduced in the Netherlands, we had another kind of lookalike program, which was called Better In, Better Out. But it never improved, it never increased in the setting of use in the hospitals or in the first line, like physiotherapists, and it was never reimbursed by the insurance companies. So there was a new program which was set up by Stefan van Rooyen, doctor here at the Radboud University in Nijmegen at the medical center. He started in 2018, which later on was published in 2019, a prehabilitation on colorectal cancer patients for exactly the same things that, of course, Stephanie mentioned. And this was the first one in the Netherlands, which also introduced a new name called Fit for Surgery. And when we look at the Fit for Surgery improvements right now, there are 31 hospitals in the Netherlands who integrated this kind of protocol, and where are two options to execute it. First of all, in this model, there are, of course, first-line healthcare providers involved, like the physiotherapist, a nutrition or dietitian, but could also be the psychological part of it, someone who can support you from your mind perspective. And there's also have to be, of course, a care professional in the hospital. So there are two options, which one of them is mainly used in the Netherlands. First of all, you have the internal within the hospital healthcare professionals, so a hospital that also has a physiotherapist and also has dietitians. And they do the job inside the hospital, but there are also external, which are the most of the situations in the Netherlands. That means that the hospital, the diagnosis there, they send the patient to a physiotherapist, which uses the program, and they send them to a dietitian to, of course, give them nutritional food during these 4 weeks. And they have to stop with smoking, they have to stop with alcohol, of course. But when we look on it, all these kinds of prehabilitation, Fit for Surgery start, we're trying to improve it. But as we see what the main focus of these is, that, and that's here also, you see it right here, because the Fit for Surgery organization is also funded right now by, well, temporary money. And it's not yet in a setting of prolonged reimbursement. That's a big, big problem. We are all proving and getting evidence that it has also a cost-effective point. This is very important for value-based healthcare. The insurance company in the Netherlands say, I want to have proof that this reduces the costs. And not only the cost for right now, of course, but also the cost for over years, when people have no longer complaints after the surgery, for example. So it's one of the things. But it's primarily focused on cost effectiveness. But you can understand when it saves costs and you understand how a hospital is financed, then you don't have to be reimbursed for that. So if someone has another opinion, please share your hand and give your own opinion for that. But if something is cost effective, then just do it in the hospital, because you have your own return on investment. Pay the physiotherapist and pay the dietitian, because the cost you spend on that are less than the effects of cost effectiveness after the treatment of the prehabilitation plan. And that's a big problem, because everyone is focusing on getting this sort of reimbursements while it already has its effective changes there. So they're not open for doing too much reimbursement for this. So that's a pity. This is my personal opinion. Precisely because of the cost effectiveness, we do not need the reimbursement. What do you think, Stephanie?
Yeah, thank you very much for mentioning that, René. Maybe you know that I wrote the chapter on reimbursement of the exercise oncology book, The Bible of Cathy Schmitz. We wrote about the situation in Germany and in the US and in different countries. And of course, that's always a topic, reimbursement. But I agree, we don't need the reimbursement because we show the return of investment. It's already done.
Exactly.
And that's an unuseful discussion. We need to implement programs. That's what we have to do. And then we will see how much money we can save. I had a very nice colleague. He was doing an internship in economy in our hospital, but before he worked in the nurse, he was a nurse, and he had a huge experience, about 30 years, when he changed his journey. And he calculated if we would employ 1.5 sports scientist, or probably a specialized physiologist in the stem cell transplantation unit, we would save 1.5 million euros per year.
Yeah.
That was just a calculation about the effects of exercise in the prehabilitation setting, in the in-hospital setting, which is very prolonged in the stem cell transplantation patients. They stay for about 6 weeks, sometimes 3 months if they have complications like GVHD or whatever. And we can save a lot of costs if we screen patients, if we do prehabilitation, if we would add techniques like applications, whatever. But we have to change the situation to save money altogether.
Yeah, exactly.
We can.
If you see the increasing numbers in the Netherlands, and in 2050, 1 on 4 people in the Netherlands has to be a healthcare professional to provide the care we need at that time.
I know. And probably you have seen some posts of our friend Nick. He posted that that the Netherlands push out, they deport the refugees who partly, as the same situation in Germany, who are well experienced, who are working in the hospitals, and they get deported. And that we can't do that. On the other way, our politicians go to Kenya or wherever in the African countries to find people who work in our environments. So it's a paradox. That can't be.
Yeah, exactly. Okay, I will continue. I'll go to some protocols, what we are having in the Netherlands, and I'll show you at the same time some of screens of the app. First of all, the fit for surgery protocol, which is used in the Netherlands, has some part which comes to physical fitness, of course, where it's, like Mattia said, a very intense program where the patient himself has to do her a lot of things to get better in a short period of time. That means 3 times high intensity interval training a week. On the right side, you see that we also have a integrated timer for setting up 1 to 4 sets. You see it here. And the timer will guide you through these interval sessions. So it's also possible to do it in home setting when someone knows how to train and knows how to be motivated, of course, when they not need supervised or assistance by a physiotherapist. But 3 times a week a hit, which has a huge impact on it. On the other side, the other 4 days of the week will be filled with low intensity at home, like walking or biking, just to have a period of time for 30 to 60 minutes to do some other kinds of activities. And when it comes to the workouts, which is also a part of it, they go to the hospital, they go to a setting where they are supervised. They're all set on a beginning, like a set point of physical fitness status, and all kinds of tests will be done. Also 1 rep maximum test. And as you can see in the left screen of the app, there are a lot of exercises selected. Green ones are already completed and the other ones are still to do. But we track, and that's very important, on the actual performance of the data which are performed. You can prescribe, but you have to need to see what people can do. Also, we track how many reps they are left they actually could do with the weight they have. So that's also one of the things to maximize the intensity levels of it, to go, for example, closer to failure in executing a set. And we also measure the rate of excessive preservation. So that's also a part of it. Of course, all these kinds of things are added with strength training, balance training, breathing training, and they are supervised in most of the time. And when it comes to digitalization, it's also very possible also to decrease the cost again, to make a different approach so people are much more a higher standard of self-management, much more motivated, to give them much more activities to do at home, so not being supervised. That's one of the things where you can differentiate in within the program, of course. Nutrition calculation, as we know, there is one of the things in the nutritional status which must be improved is the protein intake. So you can prescribe in the dashboard day by day or after training to intake an additional protein shake, for example, this picture over here. But you can also track how it is to comparing or to meet your individual levels of macro and micronutrients. You can see it in the app. It will be tracked with the food tracker, which can also track all kinds of other within the library and scanner the other food that you are eating. So in the dashboard, all these results will also be reported, and also again within the total data collection. So what we're looking for in the Netherlands when it comes to the program, 1.2, 1.5 grams of protein with a normal body weight calculation per day. So the energy intake will be calculated within our also personal side of the application when it comes to the nutrition module. There can the dietitian make their calculations on macro and micronutrients side. They can also assign some suggested foods to recipes, proteins, rich recipes, for example, but also track it on medication or other side of supplementation like vitamins, if it's possible. So you can see these are medical nutrition may be employed when someone cannot achieve those goals for total protein intake. Then supplementation is one of the things to add also over there. And what I tell you, it all can be tracked. So patients can also have insights in their own data during this fit for surgery time. Well, how's it currently? Well, traditional. Most of the time it's in-person sessions, paper-based instructions, some spreadsheets, some papers to take away home, and there it's all in. You have to manually put the registrations on it with your pencil. That's how it's been done. Or the researchers, as you know, they registered it with all kinds of Excel sheets. And one of the things is that there are less accessible not following the same protocol as prescribed, for example. But yeah, mentioned you in your presentation, you mentioned that, for example, the geographic side of a country could make it impossible patients to reach in a normal time a hospital or to reach a physiotherapist, for example. So digitalization of that is, of course, very good. On the other side, it's also how your country is organized when it comes to the infrastructure of having a healthy and a good internet site, of course, because that's one of the things you need when you go to apps. It could be very. Also, the other thing is, we call it, well, people who do not know much about digital devices like a smartphone. It's also there. There's one in the elderly group, so that's also a limitation. But our app, for example, has the possibility of a buddy. So that means that someone of your family or one of your children can also use the app to see all the same things inside the app as the patient self could see in the app. Because it can support them, of course. But one of the things, our landscape in the Netherlands is that we are very, very interested in using e-health. We don't see the limitations of that by using it. We all see just the things that are, well, have the positive sides of it. But then again, mostly temporary funded. You know it also, research setting, there's a grant. From there on, you can pay everything. And we need to have some things that are reimbursed. And for Prehabilitation, in my opinion, I told you right now, I don't think it's necessary. For the research, well, bad or false registrations, that's what we also see. People don't follow the prescribed protocol, bad registrations when it comes to attending hospitalities, they are doing that. Well, that's what we see. When you follow it by the program prescribed by Vivica, you cannot do something wrong because all's inside. The only way of a registration is in a standard approach, so you can't change it, and all the data will be collected as you want to be collected in. And you can export them also one of the things. So when you go to benefits, some from insights, accessibility, making healthcare available to a larger number of patients, personal trainings programs based on data, of course, because the data are all inside and they are related to each other. The real-time monitoring and feedback, people like it a lot that they are in contact real-time with their care professional. So that's one of the things. And when it comes to cost effectiveness, there's also some kind of things that administrative workload can be reduced a lot because of the dashboard has a lot of calculations inside which are automated. And for research, then we have live tracking of the intro programs, as I told you, use of the algorithms to be created in the evidential side directly when you want to create something. Now, when we go to one of the last things is then the upscaling part of it. When you have your intervention built on a research setting, you are the proven data that the program is effective, then you can also continue in the Vivica platform for scaling up because it's already there, it's ready to use, it's digitalized, and at that time, hospitals and the patient can directly use and take benefit of using the program. Okay, last part, next steps of our platform and Evidentio. That is, well, of course, we want to look at the value-based healthcare side. So we want to improve prehabilitation. And we have to focus on a lot of things. The program effectiveness, of course, with a lot of kinds how to do it, with kinds of a research perspective. But yeah, it can be more tuned with all kinds of data responses, more tuned on people reacting on specific program parts. We can also fully automated setup, also driven by algorithms, for example, which are turning in the next session in a high intensity level after calculated the feedback from the previous one. Also the nutrition advice, I can tell you for that we have the first trials completed. That means a patient has to answer a 110. It's a broad one. A 110 questionnaire, and that means questionnaire. That means that after answering this, there is an algorithm for analyzing it, and it will give you an advice how to schedule your nutrition, but also what kind of recipes you have to use to set up, well, let's say a supporting kind of nutrition to improve the outcomes, of course, also for the total approach. Post-surgery program would be my recommendation. So yes, we go to 4 weeks of hard training, but also there has to be a post-surgery program for example, 3 to 6 months where people are guided with the information to use it afterwards. Also for tertiary prevention. And when you come to, and that's the last step, in order to find the optimum of prehabilitation and successfully transform the prehabilitation into insured healthcare, it's well, very imperative, I think, to, 1, understand the underlying molecular factors and pathways involved in the success and failure of prehabilitation. And that means that we have to identify patients who will benefit from prehabilitation within the time that is possible to execute the program. And it also results in kind of discrimination between responders and non-responders. So if we can decrease the cost, we want to decrease the cost, we also can exclude the non-responders on first hand. So if we are going to make a profile of the non-responder with a kind of algorithm, then it's possible within the framework to identify these people and say, no, you can go much more earlier to this operation, this surgery, instead of going through the prehabilitation program. So that's one of the things. And my personal note, it's more a question, what we just discussed, the 4 weeks program could not be long enough to identify useful information. So we have to continue research for that. That's it. Thank you.
Well, thank you very much, René. It was such an insightful presentation, and with so many possibilities for the future and for actual implementation. That's a word. If there was a word cloud of this meeting, I think implementation would be the biggest one, indeed. And well, I'm here to provide the practical example, so I can tell you that we did, as you know, with the previous version of Vivica in the hospital of Sant'Orsola in Bologna, temporary founded project, again, on prehabilitation in ovarian, and after, since they saw it's useful, endometrial cancers. And the ovarian cancer patients are usually a bit older than the endometrial ones. And we use the inclusion exclusion criteria of asking the patient for sure, first of all, if they are if they have a smartphone, which is kind of obvious. The second was if they use a Gmail account. When they don't have a Gmail account on their phone, it's a barrier. It's, let's say, a note for them not to be digitally ready to use the application. And if they use some apps, like simple apps like WhatsApp, Instagram, if they use it, they were able to use the Vivica application. And as you said, we shifted the program. We used the different program for ovarian cancer patient and endometrial cancer patient. For the endometrial cancer patient, we focused more on aerobic exercise, since they have a tendency of being more overweight and younger as well. And I want to show the participant that stayed with us that long a bit of how in a Vivica license would be a pre-made program for prehabilitation. Of course, this can be personalized to a very big extent. I will quickly share my screen with you. Let me know if you see that. Please don't look at all the window that I have opened. It was a tough week. But here you are in the program function of Vivica, and as you can see here, I made an example program for to be with a couple of clicks to be shared with multiple patients at the same time. What we did, for example, in the hospital of Sant'Orsola is to made 3 levels of exercise intensity sessions. So for like based on their initial screening of the test that Stephanie was mentioning, like the 6-minute walk, the 1-minute sit to stand, and other functional measurement, they were assigned to that program. And here you can see, for example, let's say that Monday, it's in Italian, but I guess you can understand these are the weeks. And on the first Monday, let's say there is the baseline visits where we ask the patient, for example, to fill in some questionnaires. In the Vivica license, you can upload as many questionnaires as you wish. And you have also the measurement of weight, body fat, muscle mass, whatever is included in the variables. And also we can send them, for example, information and tips. For example, a welcoming message to Vivica, a video about the importance of good nutrition before surgery, which is actually what we have been talking about. And also what is more interesting, of course, the exercise part that can be performed home. For example, we have Monday, Wednesday, and Friday an exercise session at home. This is a very easy one. Let me see if I can show you here. Here we have respiratory exercises, for example, and abdominal for the abdomen. And these are my videos. And we were like giving them these videos, especially the respiratory exercises were very much welcomed for the more elderly patient, because we know, as Stephanie said, that respiratory capacity is kind of go no go for surgery for some clinicians and surgeons. And on the other days, we can assign a walk of 20 minutes, for example, to the patient. And bear in mind that all this, you can add or delete elements to this program. So really, the only burden is to make a program that is feasible. And then with one click in a research context, you can assign them to your intervention group, to your control group. And of course, there is always the possibility to a personalization of the actual intervention. So really here it was just a quick snapshot of what a prehabilitation pre-made program would mean. Like really easy to schedule, to set up, and with some click you can just send it. Of course, there are much more possibilities, but this is like a very simple example of it. I will stop share my screen. As Stephanie was saying, let me say that I have here what you said. It's the Bible of exercise oncology, and it has a bit of scratches because I was taking it in all my travels. And so after a while, I decided, okay, I don't want to ruin it, but this has been a very informative book for me, really. And there is even the chapter about the reimbursement, which now is one of the main topics of healthcare worldwide, where there is a private system like in the Netherlands with insurance company, or even a public one like in Italy. You are for sure aware of the diaspora of healthcare professional that we are subject to, and I hope it's gonna change, but we will see. So like as a quick recap, I hope we touched a lot of argument. We were delving into the actual prehabilitation modalities with Stephanie and with René, with the digital possibilities, which nowadays they have to be taken into account. Especially, I saw that myself. Before COVID, I was following patient with Pink Trainer, and the digital readiness of patient were good, but not super high. Of course, depending of age, of socioeconomic status, whatever. Now, after COVID, it has shifting, and of course, it's only being, it will only improve, I think, and especially of like thanks to the design of the Vivica application that is so easy and feasible to use, it's gonna be of great help, I think, especially in implementing prehabilitation projects. I saw we have some question in the chat from Sylvia that we had the pleasure, both me and Stephanie, to meet in the Onconauti session. And I will send you the title of the book in the chat and the author. But Lucas, I can contact you later. We know each other, so we can keep in touch and I can send you that. And I don't know if anybody has any question. Thanks for staying that late. And if Stephanie and René, you want to add something, since I enjoyed so much spending the evening with you talking about what we are passionate about, I hope there's going to be a part 2 of this chat.
Yeah, thank you so much, Mattia, for this great idea to to discuss and to show others how prehabilitation can work out and how we can improve the life of cancer patients. And I hope some politicians will wake up soon to provide all these possibilities to the patients who we can be every day as well. We shouldn't forget that we can be on the other side very, very easy. So as soon as we have patients who had a great influence in their former life, and as soon they make the same experience, they think differently about topics like that. So we hope we shouldn't wait for that long, and they are matured enough to change some how can I say, to change the strategies in healthcare and to provide value-based healthcare for patients, which is already there. We just have to implement it.
Yeah.
Yes, Mattia, same from my side, of course. Thank you so much. Thank you for all the attenders to listening tonight. It's also inspiring to see that people are staying to the end, of course, which is normally not all. But yeah, very learning. And when it comes to being motivated to contribute to this part of healthcare, we never stop. So I think keep repeating the message to the right persons. And as you say, Stephanie is right. 1 under 2 persons could get cancer when it comes to any kind of cancers. So yes, it's very nearby, unfortunately. Thank you so much.
Thank you everybody for staying here. And yes, we will do another, Lucas, of course. And feel free to reach out to me, to Stephanie, or to René for other questions via email, via LinkedIn, via postcard from where you will spend your holidays, however you want. And I thank again everybody, and keep in touch with the LinkedIn page Vivica Prehabilitation, because we will organize another one and delve more deep into this topic, which is a great one, I think.
Thank you.
Thank you very much. Bye-bye.
Thank you. Bye-bye.
Thank you very much. Bye-bye. Have a great holiday season all, and a happy new 2025 then afterward.
Same to you. Bye-bye.
Thank you.
Also.